Hi, everyone. My name is Katie Grogan, and it's my pleasure to welcome you to the third lecture in our 10-part series, Advancing Health Equity with the Medical Humanities. This series was developed in partnership with New York University, NYU Grossman School of Medicine, and the Arnold P. Gold Foundation. Our initiative is part of the Foundation's Gold Human Insights webinar series, and we want to express our deepest gratitude to the Gold Foundation for their support and collaboration on this project. I also want to recognize my partners in the development of this series, Dr. Kim Adams, who is an American Council of Learned Societies Emerging Voices Fellow at Stanford University, where her work focuses on public humanities and medical humanities, and Sharanik Bosu, who's a PhD candidate in English at NYU, where he focuses on economic thought, literary rhetoric, and public humanities. We're absolutely thrilled to have with us tonight Dr. Lauren Olsen, Assistant Professor of Sociology at Temple University. As a medical sociologist, a central tenet of her work is the belief that medical institutions have a responsibility to provide equitable conditions for students and patients to thrive. She's engaged in research looking at the inclusion of the social sciences and humanities in medical education, and how educators, physicians, and policymakers understand sources of health and healthcare disparities in the US patient population and how they may reproduce forms of racial inequality in their educational and interactional processes. She's the author of multiple papers, including a piece in the Journal of Health and Social Behavior titled The Conscripted Curriculum and the Reproduction of Racial Inequalities in Contemporary US Medical Education. Tonight, she'll be speaking with us about the current manifestations of racism in medical education, from admissions processes to patient care. We're excited to have Dr. Olsen with us live for questions and discussion following the lecture. And finally, just a few quick logistical notes. We're going to ask that folks kindly keep their mics off. If anyone runs into any tech issues, we can hop in and help you out or mute you if that's needed. Please put your questions into the chat, and you can do that as they come up. You don't have to wait until the very end. Sharanik will be monitoring the chat and will help to synthesize the questions, and he'll read them aloud for us during the Q&A portion. And lastly, we're just going to drop a link in the chat to a very brief survey. We would greatly appreciate if everyone could take just a few minutes to give us their feedback on this webinar. And this is a necessary step for anyone who's claiming CME credit tonight. So just a heads up about that. Thank you so much again for joining us tonight. And I'm now going to turn it over to Dr. Adams.
Thank you, everyone. And let me start our video.
The best healthcare is compassionate, collaborative, and scientifically excellent. Thank you for being on this mission with us to ensure humanism in healthcare for all. This is a Gold Human Insight webinar produced by the Gold Foundation and its partners.
Hello, I'm Pia Pine-Miller, Senior Director of Strategy and Business Development for the Gold Foundation. The Gold Foundation created the Gold Human Insight webinar series to bring inspirational live and pre-recorded webinars to healthcare professionals and learners. Our 2022 theme is Renewing Our Commitment to Humanism. With the myriad of challenges facing healthcare systems today, including patient disconnection, clinician burnout, and even more challenges highlighted during this time of the syndemic of COVID and social justice issues, the Gold Foundation's vision of a better future remains more urgent than ever. Today's Gold Human Insight webinar is one in a series that is part of a special collaboration with NYU School of Medicine, which is an institution that is a member of the Gold Partners Council, a group of medical schools, hospitals, and healthcare systems that are leaders in humanism in healthcare. Thank you to our presenters and our audience for everything that you do.
Today's lecture is the third in a 10-part series on advancing healthcare equity with medical humanities. These slides provide a description of the larger series and accreditation information from the NYU CME office. They are required for attendees seeking CME credit and are available to all who are interested through the Gold Foundation website.
Hi, everyone. It's great to have this opportunity to be here with all of you. As by way of introduction, my name is Lauren Olsen, and I'm an assistant professor in the Department of Sociology at Temple University in the College of Liberal Arts. My central research is on medical education and how US medical educators are attempting to address social inequalities through their curricular practices. I have a central focus on undergraduate medical education, the UME, but some of my broader research projects are on the entirety of the pipeline. And so I'm really delighted to give this talk today. And just by way of disclosure, none of the content in this presentation will include a discussion of unapproved or investigational uses of biomedical products or devices. What will we cover? So as you might know in clicking on this webinar, this is a talk on race and racism within medical education. And so the first tack of approaching this is going over terminology. So I'm going to go a brief overview of understanding the central terms of race and racism. And then we're going to chart their trajectory by starting historically. So I want to situate race and racism within both the formation of the profession's workforce, as well as its knowledge base. And these two threads are really sort of the foundation of this talk today, in the sense of thinking of how racism is embedded in the organizational practices of medical education on the one hand. So that's this profession's workforce part, as well as thinking about how racism is embedded in the sort of epistemic practices of the profession. So that is this focus on the knowledge base. And I'll be tracing those threads to the current moment, identifying the legacies of these racist organizational and epistemic practices to really think about the implications for patient as well as provider health and well-being today. And in the discussion in Q&A, I'm going to end with thinking through how you could potentially apply this to your current institution, whether you're at a medical school or within clinical practice. My big overarching goal in covering all of this for you is to think about developing this deeper understanding of how race and this racism is embedded in medical education. Then think of some of the sociological tools to develop, I guess, really this kind of grow your toolkit for diagnosing it in your current institution. And that way to sort of think of how to go about making change, right? Thinking of the first step of moving towards equity is understanding the building blocks of what needs to be changed. And of course, I'm really looking forward to a Q&A with all of you after this talk. So by way of a point of departure, social scientists and legal scholars have been doing a lot of work in trying to promote and I guess blast out to the universe a definition of race that is opposed to these previous understandings of race as biological and as genetic. And my hope is that the dangers of such classification will become very apparent. But what is race? So race, first and foremost, is conceptualized as a socio-historical construct that's premised on assumptions of differences based on superficial physical features. Here, as I have in bold and underlined, the assumptions are doing a lot of work. This classification system of race is really born out of the 18th century in Europe, when taxonomy was having its day in the sun. So actually, Carl Linnaeus, the Swedish botanist, was one of the first people to try to come up with a racial classification system, and did so, again, based on assumptions of differences, based on superficial physical features. And in fact, if you look at his classification system, the racial groups were based on color, white, black, yellow, red. And what Linnaeus did based on that was then describe behavioral attributes about these, or capacities about these groups, describing some as intellectually inferior, some as harder working, some as more nefarious in intent. And in that sense, you can really see the racist underpinnings of the construction of race. Which kind of leads me to the sort of next point in thinking about race, which is, I think, incredibly important, is that race is part of a broader relational and political system of classification. And the relational part, I think, is foundational here, because the elevation of one group or the oppression of one group is premised entirely in relation to another group. Therefore, this happens all the time when I'm defining race and discussing it with students, where students that are white are like, well, race doesn't really matter to me. And that is precisely an achievement of race to sort of naturalize whiteness as the de facto group. But in fact, it's the effortlessness that is afforded to be able to be white that is part of this system. So race is relational, and this is really, really important. Even though race is something that's socially constructed, the last sort of point of thinking of this definition of race is that it is an aspect of a person's social position that fundamentally patterns their opportunities. So what is meant by that, and what we often say in the social sciences, is that while race might not be biologically real, it's very socially real. So while it might be, a figment of the 18th century, architects of colonization's imagination, although it was invented at one point in time, it's become incredibly real. And we see this, of course, in thinking about patient health, the way that racism gets inscribed upon the body. And then, of course, we also see this in the experiences of people within the healthcare workforce, which is why I'll be focusing both on the profession as well as the knowledge that is generated. And what's really pivotal here to, I think, consider when thinking about how race was constructed and its relationship to racism is if we think about racism as the system that unevenly distributes resources and risks and value, often this construction of race and especially the quest to try to define race as biological and as genetic is really part and parcel of white supremacy. And so what I mean by that is that as different iterations from the 18th century to the present, these different iterations of trying to conceptualize race as biological, as genetic, they have been part of these broader racial and racist projects to maintain white people at the top of this racial hierarchy. And while I'm describing this as this deliberate project, because it is, often people aren't aware of the more egregious and oppressive ends that these constructions have been made in. Hopefully that will become more apparent as I describe the history. So again, just to sort of summarize this slide, while race is this socio-historical construct premised on assumptions of difference, it is part of this broader relational system of classification that fundamentally patterns their opportunities. And this construction of race as biological is really, really foundational to this racism, as a way to sort of prove or legitimize the position of white people at the top. So I'm going to begin with the history of racism in medical education and bring it to the present, now that we have these definitions out of the way. As you can see with this black and white photo with medical school in the background, here we have a class of physicians who are largely white. And that is really the sort of story of the formation of the US medical profession, which really crystallized in the wake of Abraham Flexner's report in 1910. There's been a lot of scholarship to show how there was already movement underfoot at a lot of medical schools before Flexner issued his report in 1910. But what Flexner was able to do was really expedite the tightening of accreditation standards and admissions criteria among US medical schools, as well as kind of underwrite in terms of funding from both philanthropic and government institutions, the tightening of these standards. And so you can think of, in some respects, after this sort of benchmark report in the early 1900s, that led to the sort of formal social closure of the profession. And what I mean by that, and the way that sort of race plays into that, is in the wake of this report, what you see is the closing of many Black medical schools. And in fact, before the 1960s, the medical profession was 97% white. And so this kind of captures the effects and legacy of this report. And so this sort of embeds the racial exclusion of people of color from medicine, right? 97% white. So this was more formally through the closure of Black medical schools, as well as the denial of admittance to, in particular, Black medical students to these white institutions before civil rights legislation that was prohibiting race-based discrimination. So this is on the formal end. Informally, this happened too through the discursive discussions around what it meant to be a good doctor and what an ideal doctor looked like. And if you examine the what is now Academic Medicine, their journal, or what was sort of a journal of medical education over time, and discussions at what is now AAMC, Association of American Medical Colleges meetings, but what it meant to be an ideal doctor. What you see more informally happening as civil rights legislation is coming out was this notion of the ideal doctor being men of letters, which other sociologists of education have shown to really be coding for white elite, in this case, men of letters, men. And so again, in the formation of the profession, what we observe is this sort of circling of wagons and social closure crystallizing around the image of a physician as, in many ways, a white male, but certainly as white. So this is happening in medical education over the course of the 20th century. But I will say that civil rights legislation has helped, and I'll get to that in a second. But in terms of historically, the formation of the profession goes hand in hand with the exclusion of people of color from gaining those degrees, gaining those credentials. The other thread, right, this other theme of thinking about historically how racism gets embedded in medical education, of course, is in the knowledge that's buttressing the profession. And here what I'd like to focus on is thinking about the data collection as well as thinking about the subsequent knowledge that's gained. And just as I should have said this earlier, I'm putting some citations here for scholars' work that I'm drawing upon as I'm talking about this, and hopefully they can serve as a further reference for you if you would like to read more on this. So in thinking about data collection practices, what I want to focus on is like two aspects of it. So on the one hand, you could think of the research questions that were driving data collection were premised on these racist theories that I was gesturing to earlier when I was discussing about this desire or interest or quest for finding fundamental biological differences between races. And sometimes, though, it was also in the data collection practices themselves where racism was occurring. And this was much more of a social nature, in the sense that there were theories that non-white bodies were somehow inferior or did not feel pain or just should not be, were not worthy of the same human rights that white bodies were. So I'm gonna go to the next slide to sort of talk about this. So this predates the sort of formation of the profession, but it then goes all the way into the 1970s. So it's happening alongside this crystallization of the profession that I was just describing. And what I, again, would like to emphasize is that here ideas about race as biological and a lot of ideas about the biological inferiority of particular races as a way of explaining differential health outcomes, as well as these racist data collection practices, really patterned the knowledge that was gleaned. And what's ironic is that this exploitation and experimentation led to benefits for biomedical knowledge writ large. They actually weren't premised on racial difference, like the actual knowledge that was accrued were for all humans, but they came from these racist assumptions. On the one hand, and then on the other hand, though, this is the through line that we'll get to when I get into contemporary practices, these serve as this basis that there must be something biological about race. So they did lead to the creation of some race-based metrics, which I will get to. I won't spend too much time describing these in detail, but just as a smattering of these quite honestly horrific practices, I'll just describe some of these to then get into the present. So Samuel Cartwright was a very well-respected physician, was actually trained at the University of Pennsylvania Hospital. And he is known for two central things. The first is more outrageously racist. People can point to as a potentially think of as an anomaly, but he was a leading psychiatric theory of the time, which is drapetomania, which colloquially was referred to as runaway slave syndrome. And with runaway slave syndrome, what Cartwright was trying to theorize was that there must be something mentally wrong with a Black person who would be trying to escape captivity. And this also was because he had a deep assumption that Black people were both physically and mentally inferior than white people, which leads to this second development, which was the spirometer to measure lung function. And he thought that white people had better lung function than Black people. And even in updated spirometers today, there still is a race adjustment based on Cartwright's ideas. Cartwright, just like Cartwright, Marion Sims was a very well-respected physician. Sims, while his statue was just removed last summer of 2020 from Central Park, he was a well-regarded physician known as one of the fathers of gynecology for his work that he did in developing a lot of knowledge for women, fistulas in particular. The way, though, that he was able to make these advancements was in performing horrific surgeries on Black women who didn't have any anesthesia at the time. And so then we can kind of, in moving forward in terms of time, the next I guess stop on this horrific tour is something that you all probably know more about, maybe some of these more than others, is the whole heyday of eugenics, which literally meant better breeding. And here in the context of the United States, this belief that some races had better blood or better genes than other races led to the forced sterilization of tens of thousands of people of color. This was on a state-by-state basis. Actually, California did the most of them, as well as some states in the South. And so in the southern states, they tended to be Black people. In California, they tended to be of particularly Mexican or Chinese descent. And it was this association between that that people of color were biologically inferior to white people. Of course, as other scholars have documented, this eugenics and sterilization program was imported into Nazi Germany. There is Alexandra Minastern has done rich work examining the letters between the superintendents of hospitals here in the US with Hitler. And that really advised the T4 program at in Nazi Germany before the final solution was put in place. So again, here we're seeing these ideas about race as biological leading to either experimentation or sort of horrific medical practices. This happened with the Tuskegee syphilis trials, Tuskegee syphilis experiment, which again was operating under this assumption. This researchers read a report of the course of syphilis in it was a Norwegian study, and so they wanted to understand, compare Aryans to Negroes and see the course of syphilis untreated. And this, it's notorious that these Black participants were not given treatment, even though penicillin already existed, and they were left to experience the course of this illness as part of this study to see what happened as it advanced from first to second to third phase. Gosh, it's sadly the list goes on. Another course that this is again, so both eugenics, Tuskegee, and then Kligman with the Holmesburg State Prison here, also in Pennsylvania, who did experiments on Black prisoners' skin, most terribly described in a book called Acres of Skin, because that is the way that is what he uttered when he saw the Black prisoners as potential research subjects, as well as Henrietta Lacks, right? These are all things happening in the 20th century. The Henrietta Lacks case has been given potentially among the most attention in thanks to the wonderful book written by Rebecca Skloot about both her treatment and the cell line, the HeLa cell line that was taken from her cells as she was undergoing treatment for cervical cancer, and then charting the relationship between that and her family. And that's why I sort of end here, because what the Henrietta Lacks case really shows is, again, thinking of race as relational. Here we have this person of color who ends up dying and of her cancer, and her cells go on to yield biomedical benefits over and over and over again for all humans, right? Her cells know no race, and yet her own family is too poor or is in the throes of poverty to, and so they are experiencing health problems of their own, often not able to even receive health care. So on the one hand, we see that sort of the racialized dimension of seeing how people of color continue to suffer at the hands of racism, and yet the benefits of that are accrued not only to white patients through the biomedical advances from the HeLa cells, but also to white physicians and scientists and corporations who are quite literally commodifying this one Black woman's cells. And so this is how we can kind of get to the present and see how the relationship between the oppression of one group and the elevation of another group are operating. Okay, so now getting into the contemporary manifestations of racism in medicine, I am going to pick up where I left off in thinking of what I am calling the battered pipeline. And this is in talking about the profession. So again, this first through line from past to present of thinking about how racism operates in medical education. And here, the pipeline starting all the way at pre-K in the United States to all the way up to who get to be deans in medical education. So this is a really growing and rich body of literature. A lot of this occurs, especially the pre-K work, maybe pre-K through 12, pre-K through college. A lot of this is happening outside of, say, the confines of the AAMC or academic medicine. So I'm drawing on some sociological scholarship there. But in general, there's been great work done to think of how medical schools are racialized organizations, meaning that what might seem to be race neutral, right? Thinking of all of the progress that we have made since civil rights legislation, since the medical profession was 97% white, there still are ways in which there are unequal pathways for people of color to matriculate into medical school and to thrive. And here I'm really talking about underrepresented minorities. So in terms of the composition of the workforce today, while 97% white, go as we enter into the 1960s, today in the most recent report that I read, it's just shy of 55% white. But the number that a lot of scholars are trying to focus on in thinking about racial equity is that Latinx and Black students only make up 13% of the, or it's like 12 to 13% of the current graduating classes of medical school, of medical schools, when they represent about 30%, or they're 30% of the overall population, right? So it's sort of severe underrepresentation, and that's what, when people say underrepresented minorities, that is what they mean. And so this research on thinking about how this happens, that's what's really this sort of battered pipeline idea. So the first is what we can think of as like everything, all of the inequalities that accrue to underrepresented minorities before being able to even apply to medical school. And so what some of the research has focused on is that this admissions criteria actually is racist by not taking into account all of the structural inequalities that these different groups face. And this can be in thinking about test prep for the MCAT, to all of the extracurricular activities that medical students need to engage in, to thinking about their social networks for tapping somebody to be able to shadow, all of those opportunities that are necessary in thinking about matriculating into medical school, or even gaining admittance into medical school. And so this is something that scholars have drawn increasing attention to. The second aspect of medical schools in thinking of what kind of batters this pipeline is what's called, or what I'm calling racialized cultural capital. But cultural capital is a term that was coined by this French sociologist, Pierre Bourdieu. And really what that's trying to capture is if economic capital is what would help you prepare for the MCAT and take, I don't know, a Kaplan course or something like that. I don't know what the good ones are. And your social capital is who's in your network that you could tap to shadow, to gain experience, to put that on your CV. Your cultural capital is your embodied tastes and disposition and language. And what a lot of research has shown in the context of medical schools, particularly reflected in how white students are evaluated relative to other racial groups, is that there is this racialized cultural capital. So white students are much more likely to be described as outstanding, whereas students of color tend to be described as competent or as not friendly. So what the scholarship has shown is that really it is white people's cultural capital that is rewarded in medical schools. The final aspect of this is the hostile learning environments, and there's been a large body of research documenting racial discrimination and stereotyping that's happening in both the preclinical curriculum as well as students rotate in their clerkships. And this research has surveyed both people of color as well as white folks in noting these different moments. And this happens both maybe more explicit, you could think of overt displays of racism, but it also happens more directed, say, at a student, but this also happens more implicitly through negative role modeling. And the way that scholars have documented this is in the way in which physicians or attendings or residents might discuss Black patients or other patients from other racial groups under their care. And so the sort of reifying these negative racial stereotypes. So this is one way in which the pipeline is battered. And I say this instead of leaky because I think the concept of, or what battered I think captures is how there are, if you're imagining quite literally a pipe, there is an agent behind, there are people that are battering the pipeline. It's not just that there are little holes, right? There are actors in these organizations that are creating these admissions criteria, rewarding white cultural capital, and engaging in hostile behaviors in these learning environments. So next we can, in thinking about the battered pipeline is, and maybe the effects of it, or I guess you could say another dimension of it, is this body of work that you could largely describe as identity taxation. Some scholars have used identity taxation, minority tax, diversity tax, race, ethnicity, ambassadors. And this scholarship has been published in JAMA and Academic Medicine. And what these terms are trying to capture is, so if medical schools as racialized organizations are talking about sort of the limitations on students of color, particularly underrepresented minority students, in gaining entrance or advancing along the medical school trajectory, what identity taxation is capturing is once these people become faculty, people of color become faculty members, they are subject to work that is both materially and emotionally taxing. So it's materially and often this work is in the context of engaging in diversity, equity, and inclusion work, as well as mentoring the students of color who are coming up through this battered pipeline. And so it's materially taxing in the sense that if we think of how academic medicine is structured and what is, say, monetarily rewarded or rewarded in terms of prestige, DEI work is often less valued than, say, getting a K award or running a big lab or becoming a chair of internal medicine. And so comparatively speaking, this DEI work is less materially compensated. Sometimes it's not even compensated at all, although I'm hoping that that is changing. And then attendant to that is this sort of, again, mentorship aspect where that is also sometimes uncompensated labor. And then it's emotionally taxing, both in terms of understanding that this is work that one's colleagues aren't doing, but also in terms of having to come up against everything I described earlier about medical schools as racialized organizations, and things not changing. Connected to this, but slightly different, is the last aspect that we can sort of think about as how racism manifests in the medical school itself and the sort of organizational practices there. And that is these two aspects. So on the one hand is this notion of the burden of expectation, which McKellick and colleagues have described as students of color and faculty of color being expected to engage in work in underserved communities, and particularly communities of color, and engaging in this primary care work, which, again, thinking of the material ramifications of that, those tend to be less well paid and less prestigious positions. And then this other aspect, which is actually work that I've done on what I describe as the conscripted curriculum, which really is a nice segue to think about the knowledge practices. And with the conscripted curriculum, what that entails is where students of color, in the context of their classes, often in small groups, because of their social identity, because they're perceived to be, students of color, they are asked to teach their peers and faculty members about the significance of race. And this is often in the void of other content on this. And this also comes at this material and emotional cost. So again, the thinking about what students learn in the context of the classroom, this is the next, I guess, lane that I want to stay in kind of rounding out the view of contemporary manifestations of racism in medical education. So this is, again, thinking of the knowledge buttressing the profession. So I talked about historically with some of these horrific experiments that there was a real quest or a real push to try to find or identify race as biological. And whether these came from kind of more nefarious versus more ignorant but kinder assumptions is beside the point, because there's been a host of research really questioning the validity of these scientific processes, both in thinking about how the data collection undergirding this race-based medicine has operated, not necessarily, or not just in terms of ethics that we can sort of think about with the medical experimentation and exploitation, but just in how who's enrolling in these studies and how they're making these designations about race, right? What do they do with mixed race people in the context of these data collection practices. So there's been a large amount of work that has questioned this sort of scientific validity of this medicine, and yet they still are operative in contemporary medical practice and still being taught to students. And so you can think about this in terms of treatments, diagnostic bias, and clinical guidelines and algorithms. With regard to treatments, there's a famous case with Bidil, which was, I believe, a drug for heart disease, that the FDA did not approve. And then the pharmaceutical company turned around and said, actually, it's for Black people, and the FDA then approved it. So it wasn't good enough for the rest of the population, but it was good enough. It cleared muster for Black people, right? So this is maybe more of a more egregious example. But in general, there has been consideration of race in treatment protocols, which is troublesome, to say the least. And then there is this idea of diagnostic bias, with, again, thinking of these ideas that percolate within medicine or even undergird medicine, that there must be something biological or genetic about race. And this often happens in overlooking diagnoses. So people often give the example of how people think cystic fibrosis is a white person's disease, and so cystic fibrosis is often overlooked or not considered with people of color. And then finally is this notion of clinical guidelines and the algorithms that are used to guide physician decision-making. And this is best captured in thinking of different specialties. So in a recent article, actually both of these articles, both by Bias et al. And Amuta et al., they were published in the New England Journal of Medicine. With the Bias et al. Article, they went through and looked at different clinical specialties and described the way in which race adjustments are happening in the clinical guidelines and how race is being put into different algorithmic risk output scores. And this is just like a snapshot from their article of two of the specialties. And what they describe is how the racial adjustment works, and then how that actually leads to inequalities in care based on these faulty racial assumptions. I do want to hone in on the nephrology example, because this is, I guess, you could say, a very exciting time for medical education, because many medical schools, starting with student activism efforts at the University of Washington, they have started to remove this racial adjustment in the GFR, or the estimated GFR calculation, and based on the knowledge that this is faulty and racist science, and we need to remove this classification, because what it effectively was doing was that if a white patient and then a Black patient were both to come in and have the same serum creatinine levels, the Black patient wouldn't receive treatment and the white patient would. So that meant that the Black patient just had to have a much higher threshold to be able to qualify for treatment. And this is something that scholars have been pointing to as one of the biggest explanations for thinking through why there are disparities in renal function between racial groups. So this is something that is actually on the forefront of change, which is, again, really exciting. But there are, as the Bias article captures, this is, nearly every specialty has some sort of race-based adjustment or consideration. And so this is this is something that I'm hopeful that that medical education will be addressing over time. So again, as I guess this is the sociologist in me, we love thinking of things comparatively. So while on the one hand, this race-based medicine is what a lot of medical students are learning, what we can also pay attention to is what they're not learning. And then this falls under this broader umbrella is like, they're not learning what this lecture is about today, right? They're not learning the kind of socio-historical context that might explain racial disparities and inequalities in health and healthcare. They're not learning the systemic critique of that, if we pay attention to structural racism, we could really understand, again, the sources of these inequalities and might be able to more effectively combat these inequalities. And so that is where I really kind of want to end things here today, and leave you all with some strategic takeaways. So my first strategic takeaway is that race is relational, and racism is embedded into medical education through its organizational and epistemic practices. I hope that's become quite clear. And then to leave you all with this sort of question of thinking of doing a diagnostic check, right? Taking an inventory at your particular institution of the formal and informal practices about how racism is being perpetuated, or perhaps how it's being combated, right? Thinking of how that example at University of Washington that I just mentioned. And then moving from sort of diagnosis to treatment here, I guess at an organizational level or an epistemic level, is how can you move towards more equity at your institution? So I hope we are able to talk about that today in the context of our Q&A. And if you want more information, this website is an amazing resource of all of the racism sort of historically in medicine over time. And with that, I'm also happy to answer questions beyond this session. So here is my contact information. I really thank you for your attention and hope you enjoyed this webinar.
While we're waiting for folks to put their questions in, Dr. Olsen, I have a quick question for you that I'm just wondering about from my own experience working in medical education. There has been, I'd say over the past couple of years, a really rich discussion around the inclusion or exclusion of race at the beginning of case studies or educational cases used in lecture materials. And much of that discussion centers on a couple of the concepts that you brought up in terms of race being socially constructed, but also real socially. And having sort of this tradition of including race kind of in the first line of a case presentation alongside biological data, age, sex, comorbidities, and so forth. And I was just wondering if you had thoughts on the inclusion or exclusion of race in educational case studies in medical education, knowing that we're also trying to present multidimensional narratives of our patients and who they are in the world outside of their diagnoses.
Yeah, thanks so much for that question. And thank you all for your attention and for getting to be a part of this. I think my I guess central answer to this question is in thinking of curricular practices holistically. And so I think that in contexts where if the only mention of the social context of a person's race is in a case study, and that in the sort of 4 years of undergraduate medical education, race only kind of comes up in that moment, specifically by clinical faculty members in the sort of formal instruction, that is when I think that a lot of problems start happening. And so I think that if I think that, I guess, a way in which to sort of effectively build social context into case studies is to have much more formal discussions and instruction on the history of racism in medicine, and so that there is kind of a across the board understanding of the social construction and like history of race and racism, because I think that is it is an important part of thinking of how students would get to discuss race, and how students would get to like think about how they would be in a clinical setting. The other thing, and this has been something I've been thinking a lot about more recently, that is something that really I've become like increasingly passionate about, but actually I know less about, which is thinking about the pipeline earlier. And I know some scholars like Barrett Mikulik and Fred Hafferty have done some work on thinking of the pre-med pipeline, but of really sort of thinking, I guess this would be like in terms of like the AAMC or thinking about standards across the pipeline. Because I teach pre-med students, I teach them in a sociology class. And a lot of their concepts of race and racism happen, before they get to medical school, in terms of like what they're learning. So I think that not only would it be thinking of sort of like this comprehensive education around racism that's happening at the level of UME, but thinking of that even beforehand and talking through sort of STEM professors there.
I think that also answers the first question that was asked, which I missed at the beginning. I think Jocelyn asked, can you go back to your slide of discussion so we can discuss the questions? I have Lauren, do you have the bar? I mean, I have the PowerPoint and I can share if you want.
That would be great if you could share it. Thank you.
Okay, let me see. I think that would be it.
Hi there. Am I allowed to unmute?
Yes, of course.
Oh, okay. So just wanted to thank you for your time, Dr. Olson. One of the things that you spoke about during your topic is something I've also been talking with my colleagues in medicine. The medical calculators that you referenced regarding to Bias et al. And Amuta et al. On the New England Journal of Medicine. What it comes down to, and I guess just to kind of share information so that it can also be shared at the pre-med level, is this concept that we use race as a proxy for social disparities. So in these medical calculators, we are using risk stratification for a different race, for example, in cardiology, whether we're going to prescribe a cholesterol medicine. And if you change the race to Black, it's going to, sorry, I have my kid in the background. It's going to increase the significance of whether you should start the statin or not. And what we find is we're often just mindlessly clicking in these medical calculators and stating that they inherently have a genetic predisposition to having cardiovascular health without discussing the predisposition social environment that is causing bad health in these communities. So it really comes to open up a light on like race being used as a proxy for these social disparities is something that I think would be great to like bring up to the pre-meds, because when you get to the residency level where I'm at right now, you still have students that continue to believe that inherently someone's race is going to predispose them to sickness or illness as opposed to what they have gone through in the course of their life.
Yeah, I really appreciate you sharing that, and it's nice to hear. I actually think that as I go on to teach this course, bringing in, I mean, there's there's a deliberate reason why I assign JAMA and New England Journal of Medicine articles in this segment as like, you know, for better or worse, to like lend sociology legitimacy in these spaces. And so it's even what would be even like kind of the next frontier is being able to have conversations with folks that are in residency and being able to experience it. I didn't actually end up highlighting some of her work, but one of the first sociologists to really draw attention to this is someone at UC San Francisco, and her name's Janet Shim, S-H-I-M. And she has this incredible book actually on cardiology. It's called Heartsick. And it's in it, she's less focused on cardiologists themselves, but actually on epidemiologists and the way in which they go about making these calculations and are measuring racial categories, and then regarding sort of race and cardiovascular disease. And then on the other hand, she's comparing that to interviews with people of color in particular, and the way in which they're experiencing their cardiovascular disease. And what she's able to highlight in drawing out these comparisons, I think is really sort of telling, in that the epidemiologists themselves, in their sort of backstage presentation of themselves, when they're talking to Dr. Shim as doing the interviews, they're talking about how they understand and acknowledge the complexity of race and its social processes, but through a series of steps by which they're producing their knowledge, race takes on a much more hardened and also then hard and fast kind of existence, and it becomes so much more rigid, and it gets then baked into these clinical guidelines, and then like in that process from point A to point B, that kind of complexity and nuance gets kind of completely lost. And then if you think about it, if people don't know about that process, or people don't understand the complexity by which race operates, and they're just presented with that sort of neat notion and have no other understanding of race, they might think that they're engaging in best practices, because they've become, as another sort of sociologist has described before, is like black boxed into this neat package of, oh, I'm just like looking at this clinical guideline and following it. So this is how so much of sort of racism in medicine gets uncritically or unknowingly perpetuated. So I appreciate that, the kind of race as proxy thing, to use a technical term.
All right, thank you all so much for attending. Thank you so much to Dr. Olsen for this wonderful lecture and for sticking around for questions and discussion. As we mentioned at the start of this event, this is the third in a 10-part webinar series. So we're back again July 14th with Dr. Michael Rao from NYU with a lecture entitled The Value of Life, looking at how we ascribe monetary value to human life, from insurance to incarceration. So you'll see that announcement through whatever channel you received the announcement about tonight's lecture. Thank you all again, and have a wonderful evening.
Thank you.